Welcome back to MLT 130. This is the second half of the amino acids protein lecture. We have two main categories for our plasma proteins. We have albumin and globulins, and albumin makes up about 60% of our plasma proteins. Our second category, of course, is globulins, and globulins are heme-containing proteins involved in transporting oxygen. And underneath, or falling under globulins, you have alpha 1 and 2, beta, and gamma. And we'll talk a little bit more in depth later on in this lecture about the alphas and the beta. So here we have a think about it situation. In MLT 111, which is your analysis, you are learning about the reagent strip for protein is designed to detect albumin in the urine. Wow. We also learned about this in 110 as well. But why would it be designed to detect albumin? This is because the major plasma protein is albumin. And if your glomerulus is damaged, then the albumin is the major protein that is going to be passed into your urine. So that's why it's designed to detect albumin on that reagent strip. So let's talk about specific plasma proteins. We have a pre-albumin and then we have our albumin. The pre-albumin we mainly use as a screen for malnutrition. So that's its main purpose. But our albumin, it does several things for the body. So we can use it for a lot of different things. Remember, our albumin is made in the liver, and it makes up about 60% of our total protein. Our albumin contributes to our osmotic pressure of our intravascular fluid. It contributes to about 80% of the pressure. Remember, we talked about in part 1, if there's a decrease in protein, that ends up equaling a decrease in osmotic pressure, which can lead to that swelling or edema. Also, albumin binds to substances such as bilirubin, salicylic acid, fatty acids, calcium, magnesium, cholesterol, and other dyes. Albumin decreases in malnutrition, liver disease, GI, renal disease, tissue damage, and inflammation. So we would see a decrease in protein, and it increases, our albumin increases in dehydration. So let's do a quick little check-in question here. What is the clinical significance for testing for pre-albumin? And take a second, pause the video, try to answer it on your own before you move on and get the correct answer. The correct answer is B. Low levels indicate poor nutritional status. So as promised, let's talk a little bit more in detail about the different types of globulins. Let's start out with our alpha 1, also referred to as just A1. You have alpha 1 antitrypsin to start off with. This is made in the liver. It is known as an acute phase reactant. So what is that? That is a protein that can be increased or decreased during inflammatory states. It can be increased or decreased by 25%. Alpha 1 antitrypsin can neutralize enzymes which hydrolyze structural proteins. If you have a deficiency in alpha 1, it's associated with pulmonary disease and liver diseases. Examples of pulmonary issue or disease might be emphysema. Liver disease example might be cirrhosis. Next up, for the alpha 1 category, you have alpha fetal protein. It's produced in the yolk sac in utero and provides nourishment for the embryo, and then it's produced by the liver. For testing, we test the maternal alpha fetal protein. It's a screen where we test the mother's blood to see the protein that the baby's liver produces, and this is a screening test for spina bifida. Spina bifida is a spinal cord defect. We can also test for alpha fetal protein, and if it's increased, it could indicate possible neural tube defects. neural tube defects or defects where early brain and spine tubes do not close properly, may have a bulge on the neck or spine of the fetus. Low levels in the mother could indicate increased risk for Down's syndrome or trisomy 18, which causes developmental delays in children. This is where you have an extra chromosome on chromosome 18, so you have 3 instead of the normal 2. We also have a non-maternal reason to test for alpha-fetoprotein. It's used as a tumor marker for cancer patients, so we can test adults for alpha-fetoprotein. Also under globulins is alpha-2 or A2. The first one we're going to talk about is haptoglobin. It binds with free hemoglobin in plasma. So let's talk about that, the difference between free and non-free hemoglobin. Most of our hemoglobin is in our red blood cells, but a small amount is free out in the bloodstream, in the plasma. So that haptoglobin is able to bind with that free hemoglobin out in the plasma. Then that complex is removed by the mononuclear phagocytic system. So they're taken out by things like our monocytes. So haptoglobin depletion is an indicator of intervascular hemolysis. And examples of that are hemolytic anemias and transfusion reactions. So how does this work? A low haptoglobin level indicates hemolysis because the free hemoglobin in the plasma is complexed with the haptoglobin. So that free hemoglobin and haptoglobin is complexed together. Thus, the haptoglobin will be low. So in a situation where a patient has hemolysis of the red blood cells or the red blood cells have burst, they have released their hemoglobin from the red blood cells. So normally the haptoglobin would only be taking up that free hemoglobin in the plasma. But guess what? That hemoglobin has been released in a state of hemolysis. Well, that haptoglobin is going to also pick up that released hemoglobin for the red blood cells. So the haptoglobin don't care if it's free hemoglobin or hemoglobin that's been released from red blood cells. It's going to pick it up and complex with it. So you're going to end up with low levels of haptoglobin. So that's what's going to tell us you've got hemolysis. The lab haptoglobin measures haptoglobin alone. It's not going to tell us if it's complexed with free hemoglobin or if it's complexed with hemoglobin from hemolyzed red blood cells. It's just going to tell us we've got low haptoglobin. Next, under alpha-2, you have ceruloplasmin. This is copper bound to protein. It prevents copper toxicity. Most copper is stored in the liver. We have something called Wilson's disease. This is a rare disease, and it is an increase in copper deposits in the liver and other tissues. It can even cause rings in the cornea of the eye from the copper called Kaiser-Fleischer rings. You will see a decrease in ceruloplasmin levels with Wilson's disease. So here's just a question. Why do we see decreased ceruloplasmin levels in a Wilson's patient? It's because the copper is deposited in the organs and other tissues, so it's low in the bloodstream. Here's just another question to think back about what we've already learned in this lecture. An alpha-fetoprotein test is ordered on a 65-year-old male patient. What is the purpose of the test? The purpose is this is a non-maternal AFP test. It is used to screen for liver cancer. Remember, we don't have to just screen mothers for these alpha-fetoproteins. We can also use it for tumor markers for cancer patients. Now under globulins, let's talk about beta globulins, and you should be familiar with some of these from past lectures. First one is transferrin. Remember, it is synthesized in the liver and it transports iron, and it also helps in the prevention of iron loss in the kidneys. Hemochromatosis is the excess of iron deposits in tissues. Hemopexin is a protein that kind of scavenges and removes any circulating heme. Lipoproteins, of course, transports things like our cholesterol, triglycerides, and phospholipids. Beta-2 microglobulins are found in high levels in our lymphocytes. Remember, lymphocytes are a type of our white blood cells. They increase in B neoplasms, renal failure, and inflammation. We have complement that participates in the immune reaction. Then we have fibrinogen. It's one of the largest proteins in the plasma and liver. It's actually a glycoprotein. It has a high carb content, and it's one of our clotting proteins. And then finally we have CRP, C-reactive protein. It is produced in the liver, and it's involved in inflammatory diseases. It's an acute phase protein, and it's first to rise, and it's a risk factor for cardiovascular disease. Now let's talk about immunoglobulins. Remember, there's 5 types of monoclonal immunoglobulins or antibodies. Remember, there's IgG, there's IgA, IgD, IgE, and IgM. If you have a rapid increase or proliferation of plasma cells, the primary condition this is associated with is multiple myeloma. Remember, our plasma cells is derived from our B cells, and B cells make antibodies. So let's talk about multiple myeloma a little bit more. Multiple myeloma is where your plasma cells are cancerous. Multiple myeloma causes an increase in total protein, but your albumin will actually be low because it is the antibodies or gamma globulins that are increased due to cell proliferation or rapid increase. So let's do a few review questions to make sure that we're all understanding the material we went over so far. Wilson's disease is associated with a deficiency of... Pause the video, try to answer it on your own before you go on and get the correct answer. The correct answer is B, ceruloplasmin. Okay, more trivia. Early onset emphysema or juvenile cirrhosis is associated with a deficiency of... Pause the video, try to answer it on your own before you move on. And emphysema, just for a note, is dealing with the lungs and shortness of breath, and cirrhosis is dealing with the liver. The correct answer is A, alpha-1 antitrypsin. The next question is, elevated serum protein and decreased serum albumin are associated with. You have to choose from one of these conditions. Pause the video before you move on and get the correct answer. The correct answer is D, multiple myeloma, and it is because of the antibodies. Let's talk about hypo versus hyperproteinemia. In hypo, there's a negative nitrogen balance. This is where the excretion of nitrogen exceeds the intake or synthesis of protein. The most common cause is increased plasma and water volume. Thus, it is relative. Our causes include excessive loss by excretion in urine from renal diseases, leakage into the GI and inflammation, loss of blood, malnutrition or malabsorption, a deficiency of essential amino acids, or a decrease in liver synthesis. On the opposite side of that, we have hyperproteinemia. This is a positive nitrogen balance, where there's the dietary intake is greater than the excretion or loss of nitrogen. Dehydration is the major cause. Excessive production of protein is a less common cause of hyperproteinemia, but you will find it in diseases such as multiple myeloma. So let's talk about some methodologies, or how do we test for total proteins. There's 3 different ways to test or do analysis for total proteins. There's the Kildall method, which is the classic method, and it's based on nitrogen content. This is an older method. It's not used as often. There's the refractory method, and it's only used when you want a rapid approximation. And then finally, there's the Biuret method, which is the most widely used method, and the colors change when it's proportional to the peptide bonds that are available. The normal range for total protein is 6 to 8 grams per deciliter, and in order to calculate globulins, you're going to subtract total protein from albumin. So we're going to be able to run a test to get total protein, and we're going to be able to run a test and get albumin, but we're going to actually have to do a calculation to get globulins. We can also do a calculation called the albumin to globulin ratio, or AG ratio. And of course, you're just dividing the albumin by that calculated globin number. We can also test urine and cerebrospinal fluid for proteins. In our urinary testing, of course, we can do the reagent strip test to test for proteins. If proteins are positive or present, the reagent strip is going to turn from a yellow to a blue-green color. We can also do a visual inspection of our urine cup and look to see if there's turbidity in the urine. If there's sulfoxylic acid, it could cause there to be precipitate or a haziness to urine, indicating there might be a presence of protein in the sample. And you can also do a microalbumin test, and that can be done on your chemistry analyzers. And this is an indication of neuropathy with diabetes. For our CSF protein, it's routinely performed on our cerebrospinal fluid specimens. The normal range should be between 15 to 45 milligrams per deciliter. Increased levels are present in meningitis patients, in cerebral hemorrhages, tumors, syphilis, and also multiple sclerosis patients. For measuring albumin, we have two binding dyes that we use to help us measure albumin levels. This is a direct method, and it's the most widely used method. The amount of albumin is quantitated by binding it to a dye complex, and there's usually two different dyes that can be used. There's the bromocresnel green and there's the bromocresnel purple. But the green is not as specific for albumin, as it will bind to other globulins that are available. But if the procedure is done promptly, this is not as big of a problem. So if you look over here on the right hand side, here's our albumin, and we add the dye to the sample. So the albumin and the dye kind of link up or bind together. And when it binds together, we're able to measure the albumin dye complex. So that's what we're able to measure, and that's how we're able to determine how much albumin we have. Now we need to discuss the process of serum protein electrophoresis. Electrophoresis is when you have migration of charged solutes or particles in a liquid medium under the influence of an electrical field. Protein electrophoresis is performed using a cellulose acetate or agarose gel. The agarose gel is usually preferred. We usually perform electrophoresis on serum because we don't want any complications from fibrinogen involved in our samples. Proteins are allowed to be separated by electrical charge based on their densities. Other things that are affected by the electrical field are the strength, size, and shape of the molecule, and also the temperature and the characteristics of the buffer used. Serum proteins will be in 5 different bands. Here's an example of what it looks like to have a setup of serum electrophoresis. If you look here, you have a tray that's holding a buffer solution. You have an electrode that's a positive charge, and you have an electrode that's negatively charged. These are the wells where all the samples will be loaded up. If you'll notice, when the charge is turned on, these different bands will run across this agarose gel. The heavier or more dense bands or higher molecular weight bands will stay closer to the beginning or the negative charge, and the smaller fragments or lower molecular weight bands will be able to travel farther along in the gel. The buffer that's used for serum protein electrophoresis is usually a pH of 8.6, which is alkaline. Proteins at this pH will usually migrate towards the anode, which is the positive electrode. And again, there's different things that will affect the migration pattern. Again, the net electrical charge, the size, shape, strength of the electrical charge, properties of the medium, and also temperature. After electrophoresis has been ran, the bands will be separated, the different bands of protein. So the gel or strip must be stained to be visualized. We use a Kumasi Brilliant Blue most of the time to do our staining. It's the most sensitive. The next thing we'll do is we'll run our protein strips through a decimeter, which is an instrument that measures the bands, and then they're going to display them in a series of peaks based on the amount of each band. This is very similar to the peaks that we saw on our LDH flip with our cardiac risk. I encourage you to look in your textbook at some common serum protein electrophoresis patterns. Number 1 in your textbook on that page shows you a normal patient. One of the things that the BOC Board of Certification exam loves to do is show you some serum protein electrophoresis patterns and ask you which one is normal, which one is a multiple myeloma pattern. So just be familiar with some of these peaks when it comes to electrophoresis. Number 4 in the text is showing that spike in the gamma globulin band, which is your multiple myeloma patient. Number 2 is the peaks for a nephrotic syndrome patient where there's a decrease in the albumin because that albumin is being excreted in the urine. So please just be aware of these patterns. This concludes our lecture for amino acids and proteins. If you have any questions or need any extra help, don't hesitate to reach out. I'm available in my office hours or through email or during our lab time.